Hi, this is Keith. This presentation goes along with Chapter 11, so if you haven't read that chapter yet, it's a good idea to do that first and then watch this presentation. In this presentation, we'll discuss risk and responsibilities related to contraception, the methods of contraception, and finally end with abortion. Just remember that this lecture is to support the material in the book, so there's a lot more information in the book about these topics, so be sure to read the chapter. Okay, let's get started. As you know, this chapter focuses on contraception and abortion. To set the stage for available methods, we first want to understand the context in which these methods are used, including the risks and responsibilities of unwanted pregnancy. In the United States, nearly half of all pregnancies each year are unintended pregnancies. That is, pregnancies that were either mistimed or unplanned or both. And about 42% of these are terminated by abortion. Importantly, over a period of a year, sexually active couples who do not use contraception have about an 85% chance of becoming pregnant. For these reasons, understanding methods for avoiding unintended pregnancies is important. And while they may seem the same, there's a difference between birth control and contraception. So, birth control refers to the regulation of the number of children born through the deliberate control or prevention of conception. In contrast, contraception is the deliberate prevention of conception or impregnation by any of various drugs, techniques, or devices. So this chapter primarily focuses on contraception. Understanding the types of contraception that are used is important since nearly half of the 6.1 million pregnancies in the US each year are unwanted or are ones that are wanted later in the person's or couple's lives. Most unintended pregnancies are attributable to a variety of reasons, and these might include non-use of contraception methods, ambivalence, fear of the side effects, inconsistent use, or incorrect use. All right, so here you see the most effective contraceptive methods used in 2018 by sexually active U.S. women not seeking pregnancy. Now, women using contraception include the following categories. Permanent female method was about 24%. Pill, which accounted for 16.4% of all women, a male condom, or what we call an external condom, we'll talk about that later, was 13.2%. An IUD or an intrauterine device was 12%. A partner vasectomy was 8.5%. The withdrawal and natural family planning method was 8.4%. Implant was 2.6%. Injectable, a little over 2%. A vaginal ring, a little over 1%. A contraceptive patch, under 1%. Emergency contraception, again under 1%, and then all other contraceptive methods were also under 1%. So that kind of breaks down in terms of who is using what. So women not using contraception were sort of placed in the category of no method, and those no method accounted for 11%. Okay, a reliably hot topic is whose responsibility is it to manage contraception? Now, historically, the responsibility has been with women because women bear children and have most of the responsibility for raising them. They often have a greater interest in controlling their fertility. So in the past, women have taken responsibility for it. But society no longer views contraception as being solely the woman's responsibility. Higher levels of education is a strong predictor of beliefs that the responsibility for contraception should be equally shared among men and women. Education appears to instill confidence in both partners to discuss intended family size and contraception methods. And because of higher stakes of rates of education and other reasons, the majority of partners perceive gender equality in sexual decision making and responsibility for contraception. There are a number of ways that men and other partners can take contraceptive responsibility in the relationship. So these include exploring ways of being sexual without intercourse. So this could include mutual masturbation, oral sex, or the use of sex toys. We talked about all these different things in a previous chapter. helping to pay for doctor or clinic bills and sharing the cost of pills, injections, or other contraception methods. A third way is checking on supplies, helping keep track of the partner's menstrual cycle and helping her with her part in the birth control routine. And then in a long-term relationship, if no or no more children are planned, having a vasectomy if that's an option. Reproductive health care reflects a deep commitment to supporting the family, but reliable reproductive health care was not always available. Margaret Sanger, who is considered sort of the founder of modern birth control movement, first opened an illegal clinic in 1915 so women could obtain and learn about the use of diaphragms. It wasn't until the 1960s that birth control pills even entered the US marketplace. Now, today, Title X planning program is our nation's publicly funded family planning program that provides individuals with comprehensive family planning and other prevention services. So it includes a wide array of services. Federal Title X Family Planning Program and the Affordable Care Act, or the ACA, provide some overlapping services, although some entities have raised religious and moral objections to some of the provisions in these laws. As you may know, currently the future of Title X is in question since the current administration's budget for 2026 proposes to eliminate funding for Title X programs. So the future of Title X is uncertain. Related to the idea of access to contraception is reproductive justice, which links reproductive rights such as access to contraception and other family planning methods to social justice, noting that all people deserve equal access and opportunity to access family planning services. For example, a reproductive justice perspective considers factors in a person's ability to have and raise children or not, and questions of equal access and opportunity. Okay, so what encompasses family planning services? Here you see a list of the recommended family planning services. These include contraceptive services, pregnancy testing and counseling, achieving pregnancy, basic infertility services, preconception health, sexually transmitted infection services. But there are other related preventative family or health services that accompany family planning services. And these related services include things like screening for breast and cervical cancer. And when someone who is receiving family planning and other related services, this is really an opportunity to provide other preventative health services, such as screening for lipid disorders. So it's a pretty encompassing type of services. That's not just about, for example, handing out contraceptive tools, but it's also about sort of thinking about the whole person and what kind of services can help improve their health. So, what about the need for contraception during adolescence? Now, on average, young people in the United States have sexual intercourse for the first time at about the age of 18, but typically do not marry until their late 20s. By age 20, 80% of young people have had sexual intercourse. So, for these reasons, during the first decade of being sexually active, young people may be at increased risk for unintended pregnancies and sexually transmitted infections, or STIs. But the good news is that overall teen pregnancy rate has declined, mostly as a result of increased use of contraception. However, Hispanic and Black young people are still about twice as likely to have their first birth by the age of 18 than white young people. And this is about 8 to 9% of Hispanic and Black young persons and about 4% of white young persons. So again, there's still some work to do. To reduce teen and young adult pregnancies, having access to and use of contraceptive services often depends on being able to attend publicly supported family planning centers, of which the future, as I mentioned before, is sort of uncertain. Okay, so let's spend quite a bit of time talking about methods of contraception, and there are a lot of them. So we'll kind of walk through them one by one. As we talked about earlier, contraception is the deliberate prevention or conception of impregnation by any drug, technique, or device. Contraception can occur in a variety of ways. So there are barrier methods, which place a physical barrier between the sperm and the egg. There are also spermicides, which kill the sperm before it gets to the egg. Hormonal methods, which inhibit the release of the oocyte, or sort of the egg, and intrauterine devices that prevent the sperm from fertilizing the egg. So again, we're going to kind of talk about these broad areas and then also specific strategies within these areas. Okay, before we get to that, however, how do you decide which method is best? So, one way is to sort of think of it as a number of questions to answer to kind of figure out which method might be right for you or somebody else. These questions include: do you have any particular preferences or bias? Do you know the advantages and disadvantages of each? Those are pretty clearly articulated in the chapter. So, again, take a look at the chapter to look at the pros and cons of each. How convenient and easy is it to use? Does the method protect against STIs, including HIV? What are the effects of these methods on menses? So will it make menses stop altogether or make it unpredictable or more uncomfortable? How will it affect it? Is it important that your partner be involved in the choice? What other influences might affect your decision? And finally, have you discussed this with your healthcare practitioner, which will be important? Knowledge and familiarity are strong determinants of contraceptive use, as are high income, being married, being religious, and cohabitating. In addition, technology has expanded the ways that women can track their periods, locate and access contraceptives, and accept reminders. But it should not replace professional advice. So while there are many methods for contraception, no method is perfect, and that's why it's important to get the opinion and the thoughts around from your healthcare provider. So an important consideration is the degree of contraceptive failure for a particular method. So contraceptive failure is a measure of a woman's probability of becoming pregnant during her use of a particular contraceptive method. And it's important to understand the difference between perfect and typical use of a contraceptive method. So this is an important point that we'll talk about as we discuss each of the contraceptive methods. So perfect use means that the contraceptive method uses the exact directions as prescribed. But importantly, rates of contraceptive failure are often derived from perfect use estimates during clinical trials, but rarely are these methods used perfectly in the real world. So, in contrast to perfect use, typical use refers to the way that a contraceptive method is actually used and includes times when it is used inconsistently or incorrectly, or when use may stop for a while. So when you think about a contraceptive method, you have to think about both its perfect use and also its typical use, which is probably the one that most people will want to pay attention to. So here you see the percentage of women who will become pregnant over 1 year of use of different contraceptive methods. So as you can see, there are differences in the proportion of women who will become pregnant when you consider perfect for use, which is sort of on the far right-hand side, versus typical use, which is the middle column. For example, with the pill, only 0.3% of women who use the pill perfectly will become pregnant, whereas in real world use, the percentage is 7%. Another example is the withdrawal method. Under perfect use, it would only lead to a 4% likelihood of someone becoming pregnant. But in a typical use, that percentage raises to 20%. So there's a big difference between 4% and 20%, obviously. Okay, so now we're going to talk about different methods of contraception. No doubt that one of the oldest forms of contraception is simply abstinence. So abstinence here refers to the absence of genital contact that could lead to pregnancy. One of the benefits of abstinence is that it is indeed 100% effective. However, abstinence is also one of the most difficult forms to always follow through completely. So we obviously need other forms of contraception. One of those other forms is the withdrawal method. Withdrawal, or coitus interruptus, is where the man completely removes his penis from the vagina and away from the external genitalia of the female partner before he ejaculates. Now, estimates of the percentage of women who use the withdrawal method as a contraceptive method is that 12%. So about 12% of women sort of worldwide use this method. So while it is used worldwide, the withdrawal method has a quite high failure rate, and that's around 20%. Okay, so let's turn to other methods of contraception. Probably the most widely used form of contraception in the US are hormonal methods. So let's review different forms of hormonal contraceptive methods. Oral contraceptives, or OCs, also known as the pill, are medications that contain synthetic estrogen and/or progesterone that regulate egg production and the menstrual cycle. The pill is the most widely used reversible contraceptive method in the US, used by about 14% of women. And by reversible, we mean that once a person or couple stops using the method of contraception, then the couple may become pregnant through sexual intercourse. So oral contraceptives are highly effective because they suppress ovulation 90 to 95% of the time. While in most states, oral contraceptives must be prescribed by a physician or clinic, they are available through a pharmacist without a physician or clinic prescription in some states. Oral contraceptives must be taken every day at approximately the same time to be the most effective. If they are taken consistently, then studies show that oral contraceptives suppress ovulation, like I said, 90 to 95% of the time. And it should be noted that once a person stops taking the pill, their menstrual cycle resumes within a couple of months. Okay, so while the pill is the most common form of oral contraceptives, there are other types. One of those other types is the birth control shot, known as the brand name Depo-Provera. This is an injection of the hormone progestin used to prevent pregnancy for 13 weeks. Similar to the pill, the shot works in part by thickening the cervical mucus, which keeps sperm from reaching the egg. However, for some women, the birth control shot can lead to irregular bleeding and cessation of periods, usually after 1 year of use. If the shot is used perfectly, then it's highly effective, right around 99.8%. However, in real world use or typical use, it's more like around 94% effective. A third type of hormonal method is the birth control patch. This is a thin, beige, plastic transdermal reversible method that releases synthetic estrogen and progestin to protect against pregnancy for 1 month. How this method works is that the woman wears a patch on the lower abdomen, buttock, upper arm, or torso for 3 weeks and replaces it each week for 3 consecutive weeks. After 3 weeks, the woman has a patch-free week when menstruation occurs. As with other forms of oral contraceptives, this patch is highly effective. The perfect use effectiveness rate is 99% effective, but again, in typical use, the typical use rate is around 91% effective. Okay, the vaginal ring is commonly referred to as a NuvaRing or birth control ring. It's a small flexible ring inserted high into the vagina once every 28 days. The ring is kept in place for 21 days and then after that removed for 7 days to allow withdrawal bleeding. And last but not least, the final form of hormonal contraceptive methods we'll talk about is the birth control implant. So the birth control implant, also known as Nexplanon, is a thin, flexible plastic rod inserted under the skin of the upper arm that protects against pregnancy for up to 5 years. The implant requires that a doctor insert and remove it, which requires a local anesthesia. If someone would like to become pregnant within those 5 years, then the insert can just be removed. As with other forms of hormonal contraception, it is highly effective. So here you see a picture of the vaginal ring and how it is inserted into the vagina. Sort of like a tampon, the ring can be placed anywhere in the vagina that is comfortable. There is no specific fit or need to check the position of the ring. If it causes pressure, the user may just push it further into the vagina. The vaginal ring is meant to be worn at all times, including during sex. If used perfectly, it is 99% effective. Again, typical use success rates are a little bit lower, and that's around 91% effective. All right, so the next form of contraception we'll talk about are barrier methods. Barrier methods are designed to keep the sperm and egg from uniting. The most well-known form of a barrier method is the condom. A condom, or sometimes called a male condom or an external condom, is a thin, soft, flexible sheath of latex, plastic, or lambskin that fits over the erect penis to help prevent semen from being transmitted, obviously to the egg. While there are quite a few different types of materials from which condoms can be made, Just remember that latex and plastic condoms protect against HIV and other forms of STIs. So if you aren't sure about whether a condom protects against STIs or pregnancy, make sure you read the label on the condom, which should say that it is FDA approved for these purposes. It's also important to use the right kind of lubrication with latex condoms. So latex condoms should be used with water-based lubricants, and you should avoid oil-based lubricants such as Vaseline, since Vaseline can actually deteriorate the condom. Well, we call it a male condom or external condom. Females or persons with a vagina are more likely to contract STIs during intercourse, and so male condom use or external condom use can provide protection against unwanted pregnancy and STIs. So again, all partners should be sort of invested in their contraception methods, and this is one way that both partners can benefit. Now, recent media and legal attention has been given to the idea of stealthing, which is when a man secretly removes, or again, a person with a penis secretly removes a condom during sex, even though the couple agreed to use one. So this is clearly problematic behavior, and between 8 and 43% of women reported in research studies that this has happened to them. So obviously, that is not the kind of thing that we want to happen. But in cases where that's not happening, condoms as a birthing method are highly effective when used perfectly. So if there's perfect use of it, then the effectiveness rates are about 98% effective. However, failures may occur, such as not putting the condom on correctly or taking the condom off prior to ejaculation. And so that's why the real world effectiveness of a condom is around 87%. Again, by real world, we mean typical use. So, a lesser known form of condom is the internal condom, which is a disposable, soft, loose fitting polyurethane pouch with a diaphragm like ring at each end. So I'll show you in just a minute, but the internal condom is designed so that one ring is sealed shut and used to insert and anchor the condom against the cervix. This type of condom works because it lines the inner walls of the vagina and protects against sperm reaching the cervix. Now, it's important to know that the male condom and internal condom should not be used together during sex. So again, we call that sort of double bagging. Nobody should do that. You should only use either the male or external condom or use the internal condom. All right, so here you see a picture of the internal condom on the right and how it is inserted into the vagina on the left. The condom is anchored around the cervix with a flexible ring, much like a diaphragm. A larger ring secures the sheath outside the vagina and helps protect the vulva. Now, much like the external condom, the internal condom is highly effective in a perfect use scenario, around 95%. However, typical use effectiveness rates are around 79% because people may not use them correctly. So there are other barrier methods other than external and internal condoms. The diaphragm is a shallow dome-shaped cup with a flexible rim that is placed deep inside the vagina. The diaphragm blocks the cervix to prevent sperm from entering the uterus and fallopian tubes. If taken proper care of, the diaphragm can last up to 2 years. As with other forms of contraception, there is a difference between perfect and typical use effectiveness rates. So while the results of studies vary, perfect use rates are as high as 94%, although typical use rates are around 83%. Next is the birth control sponge, which is a round plastic foam shield about 2 inches into diameter that's filled with spermicide. The sponge should be left in place for at least 6 hours after sex. However, it should not be left in place for longer than 24 hours because it can increase the risk of toxic shock syndrome. So the real world effectiveness use rates are relatively low compared to other barrier methods. Finally, the cervical cap is a silicone cup-shaped device that is inserted into the vagina. It's sort of shaped like a sailor's cap and comes in multiple sizes. The cervical cap should stay in place for 6 hours after the last intercourse. Okay, so the final barrier method that we're going to talk about is spermicide. Spermicide is a substance that is toxic to sperm. So probably the best known spermicide is naloxone 9, and it's sold in the U.S. And spermicides are available in a variety of forms, and the forms that they come in include foam, film, cream, jelly, and suppositories. Spermicides are considered most effective when used in combination with a barrier method such as a diaphragm. Both perfect use and real-world use effectiveness are lower than with other barrier methods. So perfect use effectiveness is around 93%, while typical use effectiveness is around 86%. So again, that's a bit lower than, for example, when we talk about hormonal contraceptive use. So that's why these are most effective when used with other barrier methods. Okay, so a different form of contraception is the intrauterine device. This is a long-acting reversible contraceptive method that is inserted by a doctor into the uterus. The intrauterine device, or IUD, emits either copper or the hormone progestin, both of which are hostile to sperm. All types are extremely effective. Depending on the brand, they can remain in place for 3 to 6 years and can also help reduce menstrual bleeding, cramping. IUDs are highly effective, so the perfect use rate effectiveness is 99%, but typical use effectiveness is 98%. So again, quite high. Now, current evidence does not support the belief that the IUD is an abortifacient. In other words, IUDs is not a device that causes abortions. Okay, so here you see different types of IUDs as well as how an IUD is inserted into the vagina and uterus. Once the IUD is inserted, the threads attached to the IUD will extend into the vagina through the cervical opening. After each period, it's important to check for the string of the IUD to help make sure that it's actually in place. IUDs, the birth control implant, and other similar forms of long-acting contraceptives are also known as long-acting reversible contraceptives, or LARCs. These provide highly effective protection against pregnancy, last for several years, and are easy to use. LARCs include the intrauterine device, or IUD, and the birth control implant. Now, because LARCs don't require women to use these methods daily or each time during sex, they've been found to be 20 times more effective than the birth control pills or the patch or the ring. And the American Congress of Obstetricians and Gynecologists urges them to educate patients about LARC options. In addition to these types we just discussed, there are also fertility awareness-based methods. This is a form of contraception that uses natural family planning to track ovulation and other signs of fertility in order to prevent pregnancies. There are a number of fertility awareness-based methods, including the calendar or rhythm method, the basal body temperature method, and the cervical mucus method. When all three methods are used together, this is called the symptothermal method. So as you can imagine, fertility awareness-based methods require a high degree of motivation and self-control. Among typical users of fertility awareness, about a quarter of women experience unintended pregnancies during the first year of use of these methods if they don't use these methods correctly or consistently. Okay, so what are each of these methods? The calendar method uses a calendar to find a woman's peak fertile time and safer days for sex from her longest and shortest menstrual cycles. In contrast, the basal body temperature method uses slight changes in a woman's body temperature to determine their ovulation cycle. And finally, the cervical mucus method determines a woman's stage in the menstrual cycle from the appearance and characteristics of mucus secretions of the cervix. So here's an example of the calendar method to keep track of a woman's menstrual cycles. So I'll just focus on the upper chart that you see in this particular figure. So in that upper chart, you see the probable safe and unsafe days for a woman with a regular 28-day cycle. Here, menstruation takes place on days 1 through 5. The last day of unprotected or condomless intercourse after the menstrual period is day 9. Days 10 through 17 are possible fertile or unsafe, quote unquote, days, with day 14 labeled as ovulation, plus or minus 2 days. Day 18 is the first day of condomless intercourse before the next menstrual period, and the end of day 18 marks the beginning of the first day of the next menstrual period. Okay, so the next option we'll discuss is lactation amenorrhea method, or LAM. LAM is a highly effective but temporary method of contraception used exclusively by breastfeeding mothers. This method relies on lactational infertility in the first 6 months following a birth if the woman breastfeeds frequently and has not had her first postpartum menses. This method is more than 98% effective within the first 6 months after birth, as long as a woman breastfeeds about 5 hours a day and about 6 hours at night and has not experienced her first postpartum menses. Breastfeeding women may start progestin-only methods after delivery because they do not typically suppress milk production. They can also choose non-hormonal options, including condoms, the diaphragm, and the cervical cap. Okay, so the next class of contraception methods is permanent methods of contraception, which we previously called sterilization. So, permanent method of contraception involves surgical intervention that makes the reproductive organs incapable of producing or delivering viable gametes. Those gametes include sperm and eggs. The most common type of permanent method for people with ovaries is fallopian tube surgeries. This is commonly known as tying the tubes, and the procedure is conducted through mini laparotomy, or laparoscopy. Laparoscopy is a procedure where a viewing lens is inserted through a small incision in the abdominal wall, and another instrument is used to close the fallopian tubes, usually by electrocauterization. In contrast, an Essure is a non-incisional permanent system that uses small devices to block the fallopian tubes. With an Essure, the device will form a tissue barrier that prevents sperm from reaching the egg during the first 3 months after insertion. So here you see a diagram of the types of female sterilization methods. Most permanent methods for those with ovaries are fallopian tube ligations, or tying the tubes. At a point between the uterus and the end of the fallopian tubes, each fallopian tube may be cauterized, in other words, sort of burned, closed, or it may be cut and then the newly freed ends tied. Another method, which requires no incision, blocks the fallopian tube with an inserted rod. Again, that was called an Essure. So there are a lot of questions about permanent methods. Let's take a minute to kind of note a few things about this method. First, once a permanent method has been done, no other methods of birth control will be necessary. Second, permanent methods do not protect persons against HIV or other sexually transmitted infections. So if there is a risk or exposure to STIs, some barrier method should be used. Third, sterilization does not reduce or change a female's hormone levels. Fourth, with the permanent method, a female still has her menstrual periods regularly until whatever age menopause naturally occurs. And finally, most females do not report that they have a diminished enjoyment in sex. In fact, a lot of women report that they enjoy sex more because they're not worried about pregnancy. Now let's turn to permanent methods for people with vas deferens, in other words, males. The vasectomy is a permanent method of birth control in which each vas deferens is severed, preventing sperm from entering the vas deferens and mixing with seminal fluids to form semen. So the physician makes a small incision or two to lift, cut, tie, and often cauterize each vas deferens. There's also a no incision method in which one puncture is made to reach both tubes. So this procedure only takes about half an hour, and patients typically recuperate in just a few days. However, it should be noted that viable sperm can be retained in the system for several weeks following a vasectomy. So because it can take up to 3 months to use these last sort of viable sperm that kind of remain in the system, the couple should use another form of birth control until sperm are no longer present in their semen. So when this is done properly and effectively, vasectomies are 99.9% effective, and sexual enjoyment will not be diminished. However, condoms are still needed to prevent STIs and HIV if a person chooses to have a vasectomy. Okay, so here you see a diagram of vasectomy. Again, It's a relatively simple procedure that involves local anesthesia and results in permanent sterilization. Through an incision in the scrotum, each vas deferens, or sperm duct, is cut and tied or clipped and cauterized. Sperm from the testes can no longer enter the vas deferentia and travel to the ejaculatory duct to mix with fluids from the seminal vesicle and prostate gland. And so therefore, sperm can't come out and fertilize the egg. But what happens in the event that birth control isn't 100% effective, or intercourse happens unexpectedly, or in cases of sexual assault? What options are available? Well, one option is emergency contraception, or EC, which is often called the morning after pill. This pill is taken within 120 hours after intercourse or assault that inhibits ovulation and thickens cervical mucus to prevent sperm from joining the egg. Importantly, this is not an abortion pill. Emergency contraception will not terminate an established pregnancy, nor will it cause harm to a developing fetus. There are two types of emergency contraception: Plan B one step and Next Choice one dose, which are progestin-only medications. The other is Ella, which contains ulipristal acetate. In all cases, no matter which option is chosen, emergency contraception is the most effective if it's taken as soon as possible after the event. And importantly, with the exception of Ella, most brands are available over the counter and without prescription in many cases. Okay, so now we'll turn our attention to the topic of abortion. So, as you know, abortion is a very heated topic with a lot of strong feelings around it. So, again, what we're trying to present here is sort of what we know about abortion, the different methods of abortion, and research on it. Abortion, or sometimes called expulsion of the conceptus, can happen naturally or can be made to happen. Now, to provide some context, there were over 625,000 legal abortions reported to the CDC in 2021, and this reflected a rate of 11.6 abortions per 1,000 women ages 15 to 44. A natural form of abortion is called a miscarriage, or sometimes called a spontaneous abortion, where there is a death of a fetus before it can survive on its own. So this may be due to a number of factors, including physical trauma, problems with the fetus, or problems with the physical conditions within the uterus. About one-third of all abortions in the US are spontaneous abortions or miscarriages. Abortion can also be induced in several ways, and keep in mind that early abortion methods differ from late abortion methods. One form of abortion that occurs early in pregnancies is medication abortion. Here, two pills collectively known as mifeprix, or RU486, are taken to block the activity of progesterone, a substance that helps sustain pregnancy. Medication abortion should be used within 77 days since a woman's last menstrual period began. So outside of spontaneous abortions, abortion can be induced in several ways. An important difference in what methods are used depends on how far along the pregnancy is. So, early abortion methods differ from late abortion methods. A typical pregnancy lasts between 39 and 40 weeks. So, in this graph, you see that two-thirds of abortions, around 65%, occurred at 8 weeks of pregnancy or earlier, while 88% occurred within the first 12 weeks. There are also surgical methods of abortion that are called in-clinic abortions. There are a couple of different types. With uterine aspiration, the uterus is gently vacuumed, removing the conceptus, placenta, and an endometrial tissue. This form of abortion is used for nearly all first trimester abortions. Another surgical method called dilation and evacuation uses a similar method as vacuum aspiration, but is usually performed during the second trimester and can be performed beyond 24 weeks. So here you see a diagram of the uterine or vacuum aspiration abortion procedure. First, as shown on the left, a speculum is inserted into the vagina. Local anesthesia is given for pain or sedation. The cervical canal is dilated, and a thin, hollow tube called a cannula is passed into the cervical canal. On the right side, next the cannula is attached to a gentle vacuum which draws out the tissue from the uterus. So, following the procedure, the empty uterus will deflate. An important question asked is how safe are abortions? We know that abortions performed in the first trimester pose virtually no long-term physical or psychological complications. The single greatest factor influencing the safety of an abortion is gestational age. That is, how many days or weeks has it been since the pregnancy started? So, as you might expect, abortions conducted early in pregnancy are the safest. In almost all women who have had an abortion, they will experience some bleeding after the procedure, and that could last from several days to several weeks. And many women experience temporary feelings of loss, sadness, or stress. But in most cases, these feelings are also replaced with relief and satisfaction regarding their choice. Although abortion rates are at their lowest ever in nearly 50 years, abortion is a common experience among women in the United States. While women from all backgrounds have abortions, research shows that 12% of women who have had abortions were teenagers, and more than half were in their 20s. Three-quarters of women who had abortions were from economically disadvantaged backgrounds. 33% of women identified as white, 39% identified as black, and 21% for women who identified as Hispanic. 54% of women who had abortions reported being Protestant or Catholic. So, what are the common reasons that women have abortions? Three-fourths of women cite the following reasons: inability to afford a child, concerns or responsibility for others, having a child would interfere with work, school, or the ability to care for dependents. They did not want to be a single parent or were having problems with their partner. Okay, so here you see the number of abortions per 1,000 women ages 15 to 44 across time. You'll notice that in 2017, the U.S. abortion rate reached its lowest level since 1973, and since then has more or less leveled off. Now, men also have a role to play in the decision to have an abortion. Research shows that support from the male partner vastly improves women's post-abortion well-being and adjustment. Pregnancy, for males as well as for females, can be perceived as a profound right. And after an abortion, men may feel residual guilt, sadness, and remorse. Unfortunately, it is not uncommon for couples to split up after an abortion procedure. So, for these reasons, many clinics now provide counseling for men as well as women when receiving abortion services. And as you certainly know, there is a very heated debate about the moral and legal status of abortion procedures. One commonality is that both sides of the abortion debate argue that they have the pregnant female's best interests at heart. And organizations such as Planned Parenthood have moved away from pro-life versus pro-choice labels with an updated approach that acknowledges the complexity of individual situations and a commitment to the idea of not bringing a child into the world without financial and family support. Highly relevant to our current situation are constitutional issues related to abortion. So, in the 1973 Roe versus Wade decision, a woman's right to an abortion was guaranteed as a fundamental right that is part of our constitutional right to privacy. However, in 2022, the U.S. Supreme Court overturned Roe versus Wade. This decision placed abortion policies and reproductive rights into the jurisdiction of individual states. So, states like California have strong abortion protections, while states like Texas have made it illegal. While the Affordable Care Act, or ACA, makes sexual and reproductive health care more accessible in many states, the Hyde Amendment has limited the use of federal funds in abortion-related services since 1977. So certainly there will be more legal challenges and protections around the issue of abortion, and this really makes it a difficult landscape for anyone seeking reproductive services to sort of understand what kind of services they may seek. Okay, and that's the end of this lecture.